This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Gregg from Mayo Clinic in Jacksonville, Florida. And today I have the pleasure of interviewing Laura Baker from Wake Forest University School of Medicine and Advocate Health, and Melissa Yu from Baylor College of Medicine, investigators on the U.S. Pointer study and authors on the recent JAMA publication summarizing top-line findings from this landmark randomized control trial. Laura and Melissa, thanks for joining me today.
Happy to be here.
Yes, great to be here. Thanks, Gregg.
Although some may remember 2015 as the year of the dress debate, was it blue and black or white and gold? Popularization of the term Netflix and chill and the release of the hit single Uptown Funk, I know I remember that one. Brain health aficionados are going to remember 2015 as the year that top-line findings from the Finnish geriatric intervention study to prevent cognitive impairment and disability were published in Lancet. The FINGER study provided high-quality evidence that lifestyle changes like eating better, moving more, staying socially and mentally active could slow cognitive decline in older at-risk adults in Finland. But this landmark study also raised an important question. Would these same interventions work in the land of the free and the home of the Whopper? The U.S. Pointer study was launched to address this question by operationalizing a similar multi-domain approach across 5 U.S.-based sites. Laura, can you share the motivating factors that led you and your team to implement this study?
We were just thrilled to see the FINGER results published because it shows that changes to your activities and your exposures in life might actually have benefit for brain function, and in particular for people who are at risk for cognitive decline and dementia. So we were thrilled about this. The reason we felt like we needed to take this across the Atlantic Ocean is that our people in the United States are different than those in Finland. If you've ever been to Finland, you know exactly what I'm talking about. I think you could probably get run over by a bicycle at any given point during the day. We don't live like the Finns do. We don't use healthcare like they do. We don't eat like they do. We don't move our bodies like they do. We have more heterogeneity in cardiovascular disease, and we have microcultures across the United States. And so the goal was to test whether can this kind of an intervention that worked in FINGER, if we could adapt it to the American culture. But not only adapt it, we need to increase our sample size because we have more heterogeneity. And we wanted to increase the rigor of measuring adherence to the intervention so that one day we might be able to answer the question, how much is enough?
Great rationale, and definitely agree with you. Our people certainly are different. It's one of the things that makes this country so great. And fair to say that this study, the U.S. Pointer study, represents one of the most ambitious brain health studies launched to date in this country. So tell us a little bit about the details of the study, and in particular, how did you randomize brain health?
I do want to make the point that U.S. Pointer, making the point about U.S. Pointer, it's the largest rigorous randomized controlled trial of lifestyle intervention in the world. It's not just the United States, but it's the largest in the world. The reason that's important is that our hope from the beginning was that we would have lessons learned about how to implement this kind of an intervention, how to engage participants, how to make sure that they stay, that it's sustainable, that we would have lessons learned to share with the world. So that was a really high motivation for the Alzheimer's Association to get involved and pull this study over across the Atlantic. This is a randomized clinical trial, so we really wanted to make sure that it was of highest rigor and that it would make a statement about what is the new standard using this kind of a rigorous methodology. So our participants worked really hard at the beginning to make sure that we remained in equipoise about the messaging of these two interventions. If you have one intervention that sounds better than the other, you will not have a rigorous trial. You will have selective enrollment or a selective attrition. So that was really important when we worked on how to create equipoise. And so our two interventions are referred to as the structured intervention, lifestyle intervention, and the self-guided lifestyle intervention. And we can talk more about that later, but that particular label was a key element to the success of our trial. So randomization was a 1-to-1 ratio, 50% going to the structured group and 50% going to the self-guided group. No one knew about assignment until the baseline assessments were finished and the participant was sitting in a room in front of an iPad and they hit the magic button on the iPad, and the randomization assignment, which was centrally allocated from the coordinating center, appeared on the screen. So even the person who's about to talk to them about their assignment, no one knew. We really wanted it to be a surprise for everyone. And again, to maintain that equipoise of messaging, that both groups were valuable. We made sure that was continued through all of our interactions with participants.
Critically important, I think, for any clinical trial, but especially when we're utilizing behavioral interventions that other people could probably access if they didn't like their assignment. Tell us a little bit about what separates the self-guided from the structured group. What are the differences between these two groups once they press that magic button on the iPad?
So it's referred to maybe in the JAMA paper and maybe in news articles as the more intense and less intense group. In terms of the expectations of the participant during the intervention, the structured group, basically, they were given a structured program of goals to reach and work towards that had to do with the 4 pillars that we really did focus on with both interventions. And the 4 pillars had to do with moving your body, so physical exercise, nutrition. It had to do also with cognitive or intellectual and social engagement and challenge. That's the 3rd pillar. And the 4th pillar is knowing your health numbers. So the participants were encouraged to have a sense of what's going on under the hood, and they know what their blood pressure is at all times. They know what their blood sugar is. And this was just the point of this was to raise awareness about how their behaviors are affecting their metrics. But the key difference between the two groups is the self-guided was just that. The participants were allowed to self-guide their changes in their self-selected changes in their lifestyle activities. And they made their own plans. They developed their own goals. They tried to adhere to those goals. There was no goal-directed coaching by a navigator. All participants were given a navigator, and participants met in teams of about 10 to 15 participants who were all randomized to the same group, and each group got a navigator. And so the self-guided group, they met 6 times in 2 years. 6 times. And so the navigator just didn't ever tell them what to do. It says, what are your goals? How can I help you? What resources do you need? What can I send your way to help you with your own goals? Okay, that's self-guided. 6 meetings, peer meetings with a navigator over 2 years. Structured group got a elaborate program of activities to follow on the 4 pillars. They met 38 times across 2 years, much more intensively so in the first 4 months, and then it got titrated down a bit. They were provided, each group, each team of structured participants were provided with a navigator. These are trained people through the study, but also an interventionist, which is a content specialist on the multi-domain components of the intervention. There was a lot more goal-directed coaching in those meetings. And so we tried to help folks overcome their barriers using group thinking and social dynamics. And in that sense, it was more intense. After the paper came out, and we're just as a team thinking through this a little bit, more intense. And after talking to participants, I'm not sure intense is the right word. The structured group required a bigger commitment to change. The self-guided group is a less commitment to change. That's how we would now best describe the difference between the two groups.
When I think about the differences between the self-guided and the structured group, the self-guided group received general advice similar to if a primary care physician had all the time in the world to give directed lifestyle guidance. They were given the tools, but not the really structured measurement and guidance, versus the structured group was a much more regimented or structured group. So
now, certainly, we want to know, did it work? Can you share with us some of the top-line findings from the U.S. Pointer study?
What we found is that, number one, both groups improved on a global cognitive function composite score. So that was our primary outcome. One score. One single score. We administered tests of executive function, episodic memory, and processing speed, and combined them using standard methods to create a single composite score. And so when we look at the change over time from baseline to 2 years, both groups improved. A moment ago, Melissa had said that this is a standard of care. If people had all the time in the world, they would get more of that. So I think the self-guided group was standard of care, but it's not the standard of care that we are able to provide because of time in this country. So it was, I'd say, standard of care plus. So we did see improvements in both groups over the 2 years in that one score, but we saw a statistically significant additional benefit for the structured group on that cognitive function measure. And I'm going to go ahead and throw this out now. We did some modeling because, the biggest question we have is like, it improved, both of them improved, one's better than the other. What difference does this make in real life? I mean, what's the translation to real life? And so it's a clinical trial. So people who volunteer for a clinical trial may be very different than people who do not volunteer for a clinical trial. So we can only do so much to estimate there. But our best estimate using modeling within our study, what is the change in your cognitive function from age 60 to 79 at baseline in our cohort? That tells us, on average, we can expect your cognitive score to decline by this amount each year that you get older. We have that data in Pointer, but we also used external databases to look at what is the expected rate of decline among people who are similar to Pointer. And so based on those internal and external benchmarks, our best estimate is that extra benefit, cognitive benefit for the structured group was a savings of about 1 to 2 years of cognitive aging. So we're slowing the clock by about 1 to 2 years for those people who participated in the structure.
It was really exciting to see the difference and to see that both groups improved. As we repeat cognitive testing on a population, there is a practice effect, but the statistically significant difference between the two groups is quite strong. I think that for me, as a practicing neurologist and as a practicing memory disorders neurologist who has a wait time for a new patient that is almost nearing that year of cognitive savings, this is really important and very exciting. If something like this were to be implemented, could we in our neurology offices catch up to the demand to some degree?
I agree with that in particular, having a very similar practice. And I share that excitement. And the good news, both groups improved. And better news when you're running a study, there was a statistically larger improvement in the group who was subjected or who participated in the multi-domain structured intervention. And I'm going to take this kind of paraphrasing that I think what these results seem to show is that some intervention is good and more may be better. And maybe even this kind of a structured domain can turn back that cognitive clock, as you said, 1 to 2 years, which holds a lot of promise for our patients.
We say that both groups improved, and that is our best educated estimate about what's going on. But we know that every time you administer a test, especially a cognitive test, over and over again, you get practice effects. And so some of that improvement, it's possible, it's due to practice. They're more familiar with the environment. They're more familiar with the examiners. They have a good sense of what they're supposed to do and so forth. So it's possible. And it's possible that they improved also because they know they're in a trial where they're supposed to be changing their lifestyle and they're supposed to be getting better. So there's this placebo effect that this is the whole reason that we have the importance of a clinical trial, that we have a comparator group. So I think we are saying that we saw improvement in both groups, but the bigger impact for us is that we saw a statistically significant advantage for the structured group. And that's over and above what we saw for the self-guided group. And we will know more. We're just getting started on analyzing our data, and we've got some brain imaging data with PET and MRI. We've got some sleep apnea data, objective data that helps us look at other measures that you really can't get practice. You can't benefit from practice on these measures. I think over time in the next 6 months that we will know more about how much of that is really practice and how much is it really showing improvement in that self-guided group. So I think the news is still out on that one.
Thank you for clarifying. I think it's very clear that there's a statistical significant difference here, but even more so, a clinically relevant difference here. But the effort-conscious reader may argue that a substantial investment was required to generate that statistically and clinically significant improvement in overall cognitive function. How would you reframe that critique?
I'm not sure that it's a critique. It's a statement of reality. I think in our healthcare system, this proves to some degree that, patients need help. They need help to make these behavioral changes. I counsel patients, behavioral change is hard. It's much easier to write a prescription for a pill or an injection or something like that. I think that statistically significant difference was what pans out as we analyze the data more. But if we think about it from a behavioral economic standpoint, the support makes a difference. The structure makes a difference. And so, can we translate that to healthcare policy in the US and payment policy and those types of things to provide the patients with those tools that they need to make those behavioral changes?
I think the biggest investment was on the participant side. And I think it's always important that when we evaluate, can we do this and will people do this, is to hear from the participants themselves. And what we're hearing over and over again is that their participation in this study was life-changing. There, it was a commitment, yes, and some group people had to commit more, yes, but there were no negative side effects. And so really our safety profile is magnificent, because we take really slow rollout of these interventions. But the participants' experience, what we're hearing over and over, is that it changed who they are. So investment, with that on the other side, many people, if given the right support, would be willing to make that kind of commitment.
Thinking about it from the practical perspective, we see one patient at a time in practice. How should our listeners translate these findings from this 4-pillar multi-domain structured approach to improve the care of the patient sitting in front of us?
I would emphasize to patients that these are all changes that are accessible to them, that we can make to improve our overall brain health. I think, again, acknowledging the need for support, and when counseling patients, giving them that extra question of, okay, these 4 pillars, being physically active, socially active, mentally active, heart healthy, mind type diet, show some benefit to your cognition. Who can you take along for the ride? Who can you, in your family or in your environment, who can support you in this? Because I think that's really important. We ask a lot of patients in the brief time that we spend with folks, and thinking about who else can help you, I think, is one of the most important things to take from this study.
Melissa said it beautifully, and she talked about it's the support around that person. So I think it's really important for us to say that Pointer doesn't have a prescription. Pointer is we tested a program, we tested a model, a framework, wherever you want to go with that word. It wasn't a prescription. So often people, when they reach out to us, what's the prescription? Can you send the document? And I think what we learned is that we can all Google and get a prescription of a healthy lifestyle anywhere at any time. And we've been doing it for eons. How has that changed us? Some, it has changed. Others, we fall back into our same routines from January 1st to March 1st. The program, the model, the framework that we tested had to do with the commitment, meeting people where they are, listening to them, helping them make a metamorphosis from an unhealthy person to one that they created, a new person that they created that's now healthy and who now makes new decisions based on that new perception of themselves. And so it's not just a prescription. And I think that's really important when we go to implementation. We are talking about implementation. How can we provide the model, the framework to help people get the support that they need and the expertise to help these individuals move toward these healthier selves? I think that's special expertise, but I know we have that expertise in our communities across the United States.
So let's talk a little bit more about that, the topic of partnership. And Melissa, you commented on direct partnership with the patient. We can also be honest, a study like this required and requires a lot of partners. You had scientific partners, funding partners, community advocates, and the U.S. Pointer study definitely benefited from powerful, effective partnerships, including sustained financial and technical support from the Alzheimer's Association, and if I'm not mistaken, an ongoing partnership with the YMCA, allowing your team to effectively implement interventions in a community-based setting. Now, I think we as providers also know that if we're going to successfully implement any behavioral change program, especially one aimed at improving brain health, we need to frame and encourage those kinds of partnerships at the individual patient level. So with that in mind, where can we direct our motivated patients, the ones who want to make a positive change in their overall health? What resources can we help them seek out in communities around us?
I think starting local, starting with the local Alzheimer's Association can provide some resources. Starting with your local gym, a lot of large churches have resources, including exercise and those pieces. And to go from there, I will say, I think there's starting to be interest on the health systems level and on the insurers level. A lot of our older patients have Medicare Advantage plans that have some benefits for healthy lifestyle, gym memberships, and things like that. So, also going to your insurer and starting there to look to see what you're already paying for.
Great suggestions. And again, really an individualized approach, patient by patient level.
Just to let you know what we're working on, the Alzheimer's Association has funded 10 planning grants across the United States with 10 different healthcare systems to come up with ideas for implementation that are going to be sustainable, they're going to be adoptable and accepted within that network. And so we'll know more in a year, and we're hoping to get 10 different ideas about how to do this. So I think that's in place. Number two, we are developing an implementation toolkit and it's not a prescription, it's the program that will be available to communities across the U.S. And we're hoping that will be available in the first quarter of next year. And it's really step by step. This is what you need. This is how you do it. This is how you talk to your patients. This is how you support them, so forth. So it'll be a comprehensive toolkit. And number three, what I'm learning a lot is that folks are approaching me and they say, I want to be the champion in my community. I run a recreation center. My boss is very supportive of this. We have expertise in exercise and nutrition. Can you help us just get started until these other resources are available to us? So I think communities who are interested, find a champion who's willing to find the resources in a way that's going to be fun for the community, kind of just something that an accomplishment for that community that we did this, we got this going, and we are helping our people. So I think there's 3 different avenues.
Laura, that's a great point. That reminds me that a couple of weeks ago, I gave a community talk on the Pointer results, and a couple of seniors brought their silver sneakers teacher from the Y to come to listen, to learn about the study and the intervention. So
I think this is an excellent theme here. We're talking about educating and equipping providers, we're empowering patients, and we're involving payers, giving them opportunities to be a part of this as well and benefit overall patient health. This is an incredibly ambitious study. We know this is just the start. What's next for the US Pointer study? What should we be looking forward to reading in the future as you dig deeper into this great data set?
As you mentioned, we have a large data set to start to analyze. We have data on participants' microbiomes. We have amyloid and tau and MRI volumetric imaging to start to analyze. We have data on sleep. We have data on vascular health. We have a lot of data, a lot of cognitive data, and looking at the different cognitive domains and which improved and to what degree. Much more to come in terms of data analysis. We are just getting started. And then these participants are being followed in an extension study. And so we are following them for a period of several more years to see how much sticks with the intervention and how well they do over time.
Melissa, it just reminded me that maybe we should just say that the top line results of all of our ancillary studies, we have at least 3 of our 4 with the sleep, the brain imaging, and the vascular, both peripheral and cerebral vascular findings, will all be presented at the Clinical Trials on Alzheimer's Disease Conference in San Diego this year.
Excellent. And we'll look forward to hearing more about that on a future podcast. Hopefully you'll be willing to come back and share some of these new great findings with us as well. In the few seconds that we have left together, could you summarize for me the key message that you really want our listeners to remember about this important study?
Healthy lifestyle changes do matter for brain health. I think this is what we learned in US Pointer is something we all maybe hoped would be true, and we presumed it would be true, but we did not have the rigorous scientific evidence to know that was the case. So that's one. And then the other is where you are is always the right place to start. You don't have to be somewhere or an exerciser or a healthy eater to get started. The whole program of Pointer was meet people where you are. And that's our starting point. And I think for Americans who struggle with our culture that gets in the way of regular exercise and good nutrition, I think that's a really important message, is just start where you are and find the support that you need to make.
It's a great message. Laura, Melissa, Many thanks for sharing the findings of the U.S. Pointer study with us.
Thank you for having us.
I've been speaking with Drs. Baker and Yu, authors on the paper titled Structured versus Self-Guided Multi-Domain Lifestyle Interventions for Global Cognitive Function, the U.S. Pointer Randomized Clinical Trial, which you can and should read in JAMA right after you exercise.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.